So jumping right in, we're going to cover 3 topics today. First, what are the core problems that need fixing? Everybody in this room, I think, is very well aware of the fact that the prescription coverage industry is in desperate need of being fixed. I'm going to go through an overview of what needs fixing. Then I'm going to talk about short-term fixes, and in this regard, everybody in this room can participate in short-term fixes. Everybody in this room has the power to change the prescription coverage industry. And then third, I'm going to talk about long-term fixes, which are more dependent upon big players. But I want to talk about them because I think you can influence the big players. So starting with, what are the core problems? What needs fixing? For any marketplace to function, if you think about it, you need 2 things, 2 pieces of information for a marketplace to function. First, you need to know about the quality of a product, and then you need to know about the price of the product. If you don't have information about quality and you don't have information about price, you don't have a marketplace. It's not going to work. So if you have information about quality and you have information about price, you're able to select, the marketplace, people are able to select the best products, and they're able to select the lowest cost products. This creates competition. It creates competition over the quality of the product, and obviously it creates competition over the price of the product. So you get better and better quality, and you get lower and lower prices. So to give you an analogy, think about big screen TVs. 10 years ago, I think everybody can remember, there were almost no big screen TVs, and people knew very little about them, and the quality of them was quite poor. But you can walk into basically any store, and you can compare 2 big screen TVs, and then 3, and then 4, and then 5. And you could see which ones had better quality, which ones were more precise in the view of them, which ones were getting bigger and bigger. You could see how they were mounted. You could see how thin the screens were. At the very beginning of this process, price was very high. But the products had to compete on price because when you went into the store, you could see what the prices were. And now you can get online and you can shop and you can see what the actual costs of the various TVs are. So you have information about quality, you have information about price, and what's happened. TV screens have gotten better and better and better, bigger and bigger and bigger, thinner and thinner and thinner, and the prices plummeted. They used to cost $7,000, then $2,000, then $1,000, then $800. Now you can buy a really good big screen TV for $500. You can replicate what I just described in industry after industry after industry. You need information about quality, you need information about price. That's how marketplaces function. So now let's look at the prescription coverage industry with that as our overview. So what's known about any drug's quality? So for drug, a quality is the efficacy of the drug, the safety of the drug, and the side effect profile of the drug. What do you know and what does your doctor know about any drug's quality? I would venture to say very little. That's true of your doctors, and it's certainly true of you. So there are a few drugs, typically the miracle drugs, where people actually know a lot about the drug. So a drug like Gleevec, brilliant, magnificent cancer drug. Some of you may have friends who are on it. They had death sentences, now they're on Gleevec, and they're living 5 years, 10 years, 15 years. The new Hep C drugs, miracle drugs, we actually know they have efficacy rates. Anybody who gets on them knows, the doctors know, they have efficacy rates in the 90 percentile, 95, 96, 97. We know quite a lot about their side effect and safety profiles. But now think about antidepressants. Go to your doctor if you're on an antidepressant and ask the doctor what he actually knows about the efficacy of an antidepressant. I'm going to come back to antidepressants in a little bit, but I'll tell you they know very little even though they're prescribing them in very large number. ADHD drugs, same thing. MS drugs, same thing. Oncology drugs, really the same thing. How many people are taking oncology drugs and actually know how much those oncology drugs are actually going to help them? Will they extend their lives 3 weeks, 3 months, 6 months? What were they approved on? How many people ask those questions? And if they ask the questions, how many people get answers that are actually reliable answers from their doctors? Very few. And I'll tell you, I know that because I've had cancer. And I've looked at oncology drugs. And I'm pretty good at research, and I'm pretty good at knowing what's going on in the prescription coverage industry. It's very difficult to get answers on the efficacy, safety, and side effect profiles of most drugs. So the quality information is very, very weak. So what are the implications of having very limited information about quality about drugs? First, it means we're basically often we're not well positioned to understand the benefits or the risks of taking the drug. We're also often not well positioned to compare the drugs in the same therapeutic category to determine those that will best treat a health problem. So we don't know about the actual individual drug, and then if we're trying to decide which antidepressant to take or which ADHD drug to take or which MS drug to take, if we don't know much about the quality of any individual one, we really can't compare them. Next, it means that doctors are prescribing and people are taking many drugs without much benefit. And they're taking many drugs with significant side effects and significant risk profiles. Look at what we've now seen happen with opiates. So back in the 1990s, opiates were being widely prescribed. They were originally approved by the FDA for purposes of giving them to people who had cancer and were terminally ill. But then they started getting widely prescribed by doctors who had very little information about their addictive qualities. They're still being prescribed by doctors who don't know about their addiction qualities, even now. Even now, people are being dispensed from hospitals or given in even local doctor's office 90-day subscriptions of opiates. They're addictive. Often it's 7 days worth, and people are walking out of offices with 90-day prescriptions. So, final side effect, we're spending a lot of money on drugs with very limited value. The other problem with not having information about quality is the manufacturers don't have to compete on quality, right? So if nobody knows that well how well a particular antidepressant works or particular ADHD drug works, the manufacturers in those therapeutic categories don't have to compete to get better and better drugs. They're going to compete in some other way, and I'm going to come back to that. Okay, so now what's known about any drug's price? A drug's price, its actual price, its net cost, is based on three major factors. I've listed them in blue. First, the list price of the drug, basically the average wholesale price or the wholesale acquisition cost. They're different, but let's call that the list price of the drug. And then plans are typically getting a discount off of that list price. And then plans are typically getting a rebate. So it's the list price of the drug minus the discount minus the rebate. That's the net cost of the drug. Okay, so now ask yourself how many people actually know what the net cost of any drug is. Doctors definitely don't know the list price of most drugs. Go in and ask your doctor if he knows what the list price of the drug is he's prescribing. Highly unlikely. Doctors definitely don't know the discounts that your plan is getting, and doctors definitely don't know the rebates. That's true of you too. You don't know any of those three components typically. Typically you know your copay, which is a very small part of what the total cost of the drug is. And then what about plans? For everybody in this room who's representing some form of a plan that's paying for drugs. What can plans learn? Plans can find out what the AWP of a drug is. They can find out what the discount is. They cannot find out what the rebate is on a drug-by-drug basis. Pharmacy benefit management companies, PBMs, will not tell them drug-by-drug rebates. If you don't know what the rebate is on any given drug, you don't know what the net cost is. So every plan representative in this room If you want to compare the net cost of any drug with another drug, you can't do it because your PBM won't tell you the net cost of the drug. They won't tell you how much you're getting back in rebates. If you don't know how much you're getting back in rebates on a drug-by-drug basis, you don't know the net cost of any drug. So what are the implications about a lack of information about drugs' actual prices? Doctors and patients aren't positioned to select lowest cost drugs. Plans aren't positioned to determine if their PBMs are favoring higher cost drugs or lower cost drugs. There certainly isn't any price competition. If you don't know what the net cost of a drug is, there's not going to be any price competition. And therefore, manufacturers are going to increase their market share by some other form than competing on price. So how do manufacturers, in fact, compete? If they're not competing on the quality of the product and they're not competing on price, how do they compete? How do they earn market share? I'm going to give you several basics, and then I'm going to double back to this later on. What do manufacturers do on the left side of the screen? First, manufacturers distribute coupons and discount codes. What's the result of that? People use the coupons and discount cards, and they buy higher cost drugs because they're not paying very much, so they're going to ignore the aggregate cost to your plan. Manufacturers give doctors free samples of high-cost drugs. What's the result of that? Doctors prescribe inappropriately, people use high-cost drugs again. Manufacturers fund continuing medical education for doctors. Manufacturers pay doctors to circulate in speakers bureaus. Manufacturers fund what are known as key opinion leaders, KOLs. The biggest and best doctors in the country are all being funded by pharma. Go to Harvard, go to Cleveland Clinic, go to Mayo, go to MD Anderson, they're all getting money from pharma. All of which leads to doctors prescribing high-cost drugs, which may or may not have much utility. Additional distortions that are created related to PBMs. I'm going to double back to these a little bit later. Manufacturers are making secret deals with PBMs to favor higher-cost drugs. Everybody ends up paying more. PBMs are getting manufacturers to pay them rebates, most of which they're passing through to plans, and other monies, other secret monies that the PBMs keep for themselves. Obviously creates an enormous conflict of interest. Some of that other money that they keep for themselves is based on the total cost of the drug. So what does that mean? If a PBM is getting a percentage of the total cost of the drug, the more that's spent, the more money the PBM makes. PBMs are even collecting inflation protection rebates. If the drug prices go up, the PBMs collect money back. What does that mean? The PBMs don't really care if the drug prices go up because they're making more money from it. And then finally, PBMs are paying consulting firms to feed business to them. So most plans in this room are hiring consulting firms. Do you have any idea whether those consulting firms are being paid to feed the business to certain PBMs? If you don't, you need to find out. So the implications of all of these marketplace distortions, what are they? Manufacturers are not competing on quality or price. Who's making money from all of this? Obviously the manufacturers and the PBMs. Who's getting hurt? The plans, patients, and the government, who's paying for a lot of the cost of the drugs. So what are the conclusions? The basic conclusion about what's wrong with the marketplace is the incentives are all distorted. The incentives should be to compete on quality and price. That doesn't exist in the prescription coverage marketplace. And the second conclusion is, which is the piece I'm going to come to next, PBMs are often working against plans and patients' interests. So the question is there any way to change this? Short-term fixes. As I said, these are fixes you folks can impact. Every one of you has the ability to impact this. And I'm going to focus on the PBM issue because most plans have contracts with PBMs. When I talk about PBMs, I'm also talking about insurers. If your plan has a contract with an insurer instead of a PBM, think in terms of the insurer. So how do you improve information about quality? Well, the first thing you should be doing is saying to your PBM, you're making a lot of money, PBM. We have our contract with you. We see what your return on investment is, Express Scripts and Caremark and Optum. You're making a lot of money. Why aren't you publishing information about the quality of drugs? So we'll know, and so our patients will know, and so our patients can walk into their doctor's offices informed. So I'm going to give you an example of the kind of information I'm talking about. I'm going to use a drug called Abilify. You've probably seen advertisements on it. This is just one example of what everybody should know about every drug. So Abilify was approved by the FDA in 2002 for schizophrenia, and then in 2007 as an antidepressant. I'm going to focus on the antidepressant use. It was approved by the FDA not as a first-line antidepressant, so you're not supposed to start off with it. It was approved as a second-line treatment, and it was approved not to be used alone. So anyone who's taking it as a first line, or anyone who's taking it alone, is not taking it based on the way it was approved. How many doctors know that? I would venture to say a lot don't. What else do we know about it? We know that 2 clinical trials were submitted to the FDA. They both had almost identical conclusions. The clinical trials showed that a very small number of people, very small number, actually had a very marginal improvement in their depression. Very marginal. I'm going to show you the details. We also know that more people experienced a very serious side effect called akathisia. It's kind of a Parkinson's-like syndrome of the shakes. And another group of people also experienced significant weight gain. So here's the actual details about Abilify in those 2 clinical trials. The top 2 lines talk about the efficacy, and the bottom 2 lines talk about side effects safety profile. And what this little chart shows, and this is the kind of information I'm talking about, quality information that should be out in the marketplace on every single drug. So this shows what those 2 clinical trials proved. Abilify is the second column in from the left, the placebo is the third column, and then the conclusion is the fourth column. So the clinical trial took about half the group was put on Abilify, another half was put on a placebo. They didn't know which drug they were on. What were the results? So first 2 lines in terms of efficacy, they were measuring depression on a 60-point scale from 0 to 60, so basically 61 points. And when they measured the depression, after the clinical trial, 2 clinical trials were over, they found that Abilify people were about 9 points less depressed on the 61-point scale. Not a lot. The placebo people were 6 points less depressed. Okay, so there was basically, far right column, a 3-point differential. Because a lot of people on the drug, even though they were taking a placebo, thought they were less depressed. Okay, that's the placebo effect. That's true in almost all antidepressants. Give people a sugar pill, they'll think they're less depressed if you tell them it's an antidepressant. So the actual effect of Abilify was 3 points less depressed on a 61-point scale. That's very marginal. Okay, now how many people actually got that benefit? Well, Abilify, 26% of the people got the benefit. The placebo, 15% got the benefit. So altogether, about 11% of people experienced about 3 points less depression. Not very effective drug. So about 1 in 10 people were about 3 points less depressed on a 61-point scale. How about the side effects? In terms of this inability to sit still, kind of a movement disorder like a Parkinson's-like effect, 25% of the people who were on Abilify had it. 4% of the people on the placebo had it, meaning that about an extra 21% experienced this. So remember, Abilify had an 11% benefit, and you got a 21% movement disorder problem. And then finally, how many people gained 7% or more of their body weight? 6% on Abilify, 1% on the placebo, 5% gained that much weight. So when I'm talking about what do we know about drugs, how many people on Abilify know this when they're taking it? How many doctors know this? Why aren't PBMs publishing this kind of information, drug by drug? Why isn't the government publishing this kind of information? If everybody had this kind of information on Abilify, I have a question to ask you. Would the sales of Abilify have looked like this? They're dropping off at the very end because Abilify lost its patent protection, so now there's generics. But the first several bars there show Abilify sales of over $2 billion in 2011 and 2012, and in 2013 and 2014 of about $1.5 billion. If doctors all knew the information I just described and patients all knew the information I just described, do you think Abilify would have these kinds of sales? So everybody should be pushing to get more information about drugs in the market. You should be saying to your PBM, every plan, why don't we have this? You should be saying to your government representatives, why isn't the FDA publishing this? It's not that hard. So other ways to improve information that would be less detailed than that, obviously you can be providing information to your plan beneficiaries. The coalition here could be providing information. You could provide it through a newsletter, through the periodic distribution of articles in your open enrollment periods. You could be covering topics like the following. You could write an article basically titled, "Unlike other products, older is better than newer when it comes to drugs. It's always better to take an older drug that's been on the market, that we know a lot about, that we've seen the side effects and safety issues arise, than it is to take a new drug, with a single exception of these miracle breakthrough drugs. Better to take generics than a new brand drug in a therapeutic category." You could be writing articles about how to deal with pain besides taking opiates. Articles about how quickly can a person become addicted to opiates and other painkillers. How to take sleeping pills wisely. You're not supposed to take sleeping pills every night. Bad idea. Not the way they were approved. Also not supposed to take proton pump inhibitors every day. It's not the way they were approved. It's not the way they're supposed to be used. But there's millions of people doing it, including your plan beneficiaries. You could be writing articles explaining how you should always ask your doctor about a drug's efficacy, safety, and side effects. You should be pushing them to be able to give you that actual information. And then you could be writing articles about making a brown bag appointment with your doctor and pharmacist, where you tell your plan beneficiary, go to your doctor, put all the meds you're taking into a brown bag, take them in, and make them examine the drug-to-drug interactions. Because if you're taking 4 or 5 or 6 or 8 drugs, you need to continuously look at drug-to-drug interactions. You need to get off of them whenever you can. You shouldn't just get on a drug and stay on it. Okay, now we're going to turn to price, which is where you can really make a difference. And this is the most complex part of this presentation, so I urge you to try to focus in on it. It gets complex. There's a single document that's controlling your plan. It's costs and your plan services. It's the PBM contract. Now, you may glaze over when it comes to contracts. You may think they are boring. They are. I spend most of my life looking at them. They are really boring, even for a lawyer. But it's the document that's controlling everything. You've got to pay attention to what's in it. You particularly have to pay attention to what's in it because it is stuffed with loopholes. Every plan rep in this room, I will tell you, your contract is stuffed with loopholes. There's not a single one of you that's escaped. I know that because I have seen hundreds and hundreds and hundreds of PBM contracts. And I've never seen any that are not stuffed with loopholes. I've seen government contracts, state government, local government, insurance company contracts, Anthem's contract, where they had to sue Express Scripts, stuffed with loopholes. One of the biggest insurance companies in the country, they signed a contract with Express Scripts that was filled with loopholes. So if your plan, and every other plan in this room, does its homework, goes and looks at its contract, and takes steps to eliminate the loopholes, you're going to change the marketplace. As long as PBMs can stuff their contracts with loopholes, nothing is going to change. Okay, I'm going to give you 7 examples of loopholes. Loophole number 1, brand drug and generic drug guarantees in your contract are basically worthless. You've got a whole bunch of retail and mail, brand and generic drug guarantees. They're basically worthless. Why are they worthless? Because the term brand drug and generic drug are defined very ambiguously. So if you have a brand drug guarantee and a generic drug guarantee, and you don't know what's a brand drug and you don't know what's a generic drug, the guarantee is worthless. How are they defined? Basically, there's 3 loopholes in them. I'm going to give you a summary of the 3. If you go home and look at your contracts, you'll see one of these 3 applies. The PBM says, we're going to use a proprietary algorithm to define what's a brand drug and a generic drug. Do you know what their proprietary algorithm is? Can they change their proprietary algorithm anytime they want? If they can define brand drug and generic drug using their own proprietary algorithm, they can define them however they want. So you're going to have a brand drug guarantee, but you don't even know which drugs are going to fit into the category. You're going to have a generic drug guarantee, but you don't even know what drugs are going to fit into the category. There are thousands of contracts that define brand drug and generic drug saying, we, the PBM, have a proprietary algorithm. There's also a lot of contracts, thousands of them, that say, we, the PBM, have the right to classify drugs as brands or generics in our discretion. That's not a definition. Finally, there are many, many contracts, thousands as well, that say, we will define brand drug and generic drug using First Data Bank's information fields. Well, First Data Bank is a national reporting service. It doesn't have an information field saying brand drug or generic drug. It has lots of information fields, but nothing saying brand or generic. So when a contract references First Data Bank, it's basically meaningless. So why does it matter that your definitions are so ambiguous? Ambiguous definitions mean your pricing guarantees are useless. And I'll give you a real-life example showing you what I'm talking about in case you're glazing over. Here's my real-life example. Suppose you walked into the fish store and you saw a big advertisement. And the advertisement said, all fish guaranteed to be $7.95 or less per pound. And next to the word fish, there was an asterisk. And the asterisk said, the grocery has the right to decide which fish are included in the guarantee. Would you put any stock in that guarantee? Ambiguous definition of fish. So if you have a contract guarantee in your contract that says all brand drugs will meet AWP minus 15%, you don't know what a brand drug is, it's as good as my fish guarantee is. You don't know which drugs are going into the category. You don't know which fish are going to be $7.95 per pound. They could charge you $7.95 for the $2.95 cod, and for everything else they can charge you whatever they want. So obviously you cannot put any stock in that fish guarantee. And obviously if you go into 2 stores, and one store says all fish $7.95 a pound, and the other store says all fish $5.95 per pound, the store that's selling at $5.95 per pound is not selling the fish any cheaper necessarily. They still can charge you whatever they want for any fish that's excluded from the guarantee. So when you go and you take your contract and you say, well, I used to have a discount of minus 15%, but now my PBM gave me a discount of minus 18%, it's not worth anything. They still haven't defined which drugs are going into the guarantee. Your contract has probably 12 guarantees for brand and generic drugs. They're all worthless. Ambiguous specialty drug definition means the same thing is true for specialty drugs. These very high-cost drugs that everybody is so worried about. There's a definition in your contract. Go and look at the definition section. You'll see a definition for specialty drugs. It's going to read something like this. Specialty drugs may be any high-cost drug that may require special handling, or may require this, or may require that, or may be a biotech drug. That doesn't tell you anything about what specialty drugs are. PBMs can move drugs in and out of that category as much as they want. It's just like the fish guarantee. So if you have a guarantee, all specialty drugs will be AWP minus 16%, it's just like the fish guarantee. You don't know which drugs are going in the category. right? So what's the implication of just those first 3 loopholes I told you about? I just described brand drug and generic drug guarantees for all retail and mail drugs. Means your retail and mail guarantees are worthless. I just described specialty drug guarantees. I told you they were worthless. I've just covered all the drugs that you're dispensing. Retail and mail, brand and generic, and specialty. They're all worthless. You've got pricing terms and guarantees in your contracts that are worthless. Can there be price competition if every PBM contract in the country has worthless guarantees? How are you going to get price competition? What's your PBM doing for you if they're giving you contract guarantees that are worthless and then improving, quote unquote, the guarantees by changing the numbers? No more than a grocery store would do if it went from a $5.95 guarantee to a $3.95 guarantee for fish when it gets to define what's a fish. You can't have a contract that has worthless price control guarantees in it. You don't have price controls. Loophole number 3, rebates. Here's the definition for rebates that's likely in your contract. Something like this. There's a lot of different definitions, but it will read something like this. Rebates means any payment by a drug manufacturer to a PBM pursuant to a formulary rebate agreement that's directly attributable to the utilization of drugs. So notice first the reference to a formulary rebate agreement. Well, suppose they write an agreement that's not a formulary rebate agreement. Suppose they write an agreement with a manufacturer that's an inflation protection agreement, or that's a health management agreement, or that's a data sales agreement, or it's any other label they want to invent. Then if they get money back, it's not going to be a rebate because the definition just says it has to be in a formulary rebate agreement. Similarly, the definition says it has to be attributable to the utilization of your drugs. Okay, well, if they get an inflation protection agreement back from the manufacturer saying if your drug goes up this much in price, you have to pay us back money, that's not attributable to your utilization. That's attributable to the drug price going up. That means they get to keep the money and you don't. So the PBMs are collecting all this money and you're not getting to keep it. They're not having to pass it through to you. That means they're collecting a lot of money and they have a serious conflict of interest with you. They're negotiating with the manufacturers, and some of the money's going to get to you, and some of the money's going to get to them. And you don't know which money's going to get to them. You're trying to get all the money back from the manufacturers in the form of rebates, but they have a conflict of interest. They're negotiating deals with manufacturers where they're getting to keep a lot of the money. And you don't even know about it, because they won't tell you what's in their manufacturer contracts. So here's another way to think about the problem. On the one hand, PBMs are negotiating contracts with clients. They're agreeing to pay back rebates to you. On the other hand, they're negotiating contracts with manufacturers. And they're calling those contracts rebate contracts, price protection contracts, health management fee, data sales fee contracts, et cetera, et cetera, et cetera. Any label they want to invent. Any money that they tell the manufacturer to pay them that's in the column on the right, you don't get back as a rebate. They could have called it a rebate, but they don't. They call it something else, you don't get it back, which means they have a serious conflict of interest. Another rebate problem. PBMs are winning their RFPs, and they're winning new clients, and they're retaining their old clients by promising more and more and more rebates. So while they're keeping a lot of money, they're also giving you back more and more in rebates. But what's the problem with that? They claim the rebates are reducing your costs, but many times they are rebating drugs that are very high-cost drugs when there are very low-cost drugs available. So if you take a diabetes product that costs $8,000 a script, and you say to the plan, I'm going to give you a $2,000 rebate on this, bringing it down to $6,000, but you don't tell the plan you're getting a rebate on that drug, you just give them back $2,000. And the plan could have bought a $30 diabetes drug instead. So now the plan gets a bundle more in rebates, but they got it off of a very high-cost drug they should have never allowed to get dispensed. The PBM isn't helping them. They're rebating high-cost drugs that should never have been dispensed in the first place. So they're luring you in with lots and lots of rebates on very high-cost drugs. They should be excluding all those high-cost drugs, not covering any of them. PBM contracts also don't require PBMs to provide drug-by-drug rebate information. This is what I was talking about before. In order for you to be able to compare drugs' prices, you need to know drug-by-drug rebate information. You need to know the net cost of drugs. If you go to your PBM and say, tell me net cost information, they won't tell you. They won't tell you. If you look at your contract, you'll see they don't have to tell you. The contract makes very clear they're not going to give you drug-by-drug rebate information. If you don't know drug-by-drug rebate information, you don't know the cost of any drug. How can you not know the cost of any drug? You're paying for them. It would be like walking into a Costco to buy a TV, and the Costco says, I won't tell you the cost of the TVs, just buy them. Who would do that? Who buys millions of dollars of products without knowing what the costs are? Who signs contracts that say we won't tell you the costs? You're not allowed to know them. So if you don't know the net cost of a drug, you can't look over the shoulder of the PBM and discover whether they're favoring higher cost drugs. You can't look over their shoulder to see whether they're properly excluding the right drugs and including the right drugs. You can't tell whether they're tiering the drugs properly. You can't tell anything about what they're doing because you don't know the net cost of the drugs. They're basically saying to you, trust us, we'll do it for you, we'll do it right. But I told you earlier, they're collecting all kinds of money back from manufacturers that they're keeping for themselves. So they're not in a position to say, trust us. And in fact, if you look at their formularies and you have a significant enough amount of information about drugs, what you find out is they are excluding more and more drugs, but and that chart shows you the increased number of drugs that two of the large PBMs are excluding. It's grown more and more and more. But if you look at their formularies and you see what they're excluding, you'll see in many instances they're not excluding all of the right drugs. They're often leaving many high-cost drugs on their formularies. And I'm going to give you some examples of this. Almost all of you are covering these drugs. So the standard formularies of most PBMs cover the first two, Vimovo and Duexis. They're combination drugs. They're called combo products. Vimovo and Duexis, they put a proton pump inhibitor on the outside of the drug. It's something that coats the stomach. And on the inside of the drug, they put like an aspirin product or an NSAID, which irritates the stomach linings of some people. So it's a very clever little idea. Coat the stomach first, and then for those people who might get a stomach ache from aspirin, they won't get a stomach ache because the stomach was coated with the proton pump inhibitor when it was first dissolving. So that's a clever idea. But proton pump inhibitors are available over the counter, and aspirin is available over the counter. And if you combine the two yourself, first take the proton pump inhibitor, then take the aspirin-like product. If you do it yourself, it'll cost you about $20 to $30 a month. What are Vimovo and Duexis costing your plan? Somewhere around $2,000 a month. Are you willing to spend $2,000 a month for Vimovo and Duexis because a PBM is favoring it on their formulary? $2,000 a month for Vimovo and Duexis? They're over-the-counter combo products. Your PBM also probably has Solodin and Absorbica on your formulary. Those are acne treatments. They cost more than $1,000 a month. Should the PBM have them on their formulary? Definitely not. Are they on the formulary? Definitely so. Why? You don't know, because you don't know the drug-by-drug rebate information. You don't know how much money the PBM's collecting from the manufacturer to put them there, and how much of that money they're passing through to you in rebates, and how much of that money they're keeping for themselves. You're blind. You don't know a thing about any of that information. Then there's Restasis and Zedra. They're eye drop treatments. Most people are using them for dry eye. There's over-the-counter dry eye treatments that you can buy for $4 in the pharmacy. What do Restasis and Zedra cost? More than $400 for a 30-day treatment. Then there's lidocaine gel. You can buy lidocaine over the counter. What are you spending for it? It's a pain gel that you rub on your skin. You can buy it over the counter for a few bucks. You're spending $240 for a 30-day treatment. And finally, there's Glumetza, one of my favorites. It's a diabetes treatment. It costs $8,000 for 30 days. There's many, many diabetes treatments. Glumetza is no better than any of them. Most diabetes treatments, the generics run $4 to $30. The brands run $200 to $400. If you're still covering Glumetza, you're spending $8,000 for one person per month, almost $100,000 a year, because the PBM still has it on their formulary. Loophole number 7. Most PBM contracts are for 3 years, and you're locked in for those 3 years, and then they automatically renew. And the pricing terms and guarantees in the contracts are static for the 3 years. Even though the marketplace is continuously changing, your pricing terms and guarantees, which I've told you are basically worthless, they're static. You can't change them. The marketplace is changing so much, I've given you a headline from a little newsletter journal that our firm gets. Drug discounting to insurers has soared from 28% to 41% in 5 years. If you're sitting on a contract that's 3 or 4 or 5 years old, you're missing out on that. So would you go to a grocery store and say, I'm going to shop here no matter what for 5 years? Would you buy all your products from anybody no matter what for 3 years or 4 years or 5 years? Why are we locking ourselves into contracts for 5 years? So here's how your plan can change the marketplace. You want to change the marketplace, every plan in this room should do something. They should look at their contracts, take this little slideshow home, compare some of what I've described to your own contract. I guarantee you what I've described is in your contract. And then the next time you're in a position to change your contract, here's what you should do. And you'll see the difference between what I've just described and what you could do. First, pin down what's a brand drug and a generic drug. Don't accept the fish guarantee like I just described. Get a fish guarantee that says the following fish are going to be contained in my fish guarantee, and list all the fish. So for brand drugs and generic drugs, you need to use what are in Metaspan called MONY fields of information. I've got articles on our website. You can read about this and exactly what you need. You need to pin down brand and generic drug definitions. You need to pin down your specialty drug definition. How do you do that? Say specialty drugs are the following drugs, attach an exhibit list, and cover all 1,000 drugs. Now you've pinned it down. And then you need to get a guarantee on every one of those drugs. Now you have a price control over specialty drugs. Pin down the definition, get a discount for every single drug in the definition. Now you have control over your specialty drug costs. But you need to do more than that. You need to get a default discount guarantee for all the new-to-market specialty drugs that come on the market. There's 30 to 40 new specialty drugs entering the market most years. You've got to get a price control over them. So make your PBM give you a good default discount guarantee. Automatically, we're going to get this guarantee, the contract should say. You'd be amazed how good the guarantees are we're getting. They're better than single digits, automatically coming on. And then you need something more. You need 100% pass-through of all third-party money, not just rebates, all third-party money. PBM, you cannot keep any money. 100% of whatever you get from any manufacturer, we don't care whether you label it rebates, we don't care what the name of the contract is, 100% of it's coming back to us. You can get that. We get that for our clients. You can get that. Nobody should have a contract which lets the PBMs keep money. It creates a conflict of interest that's very wide. You also must have the ability to get net cost information. You must be able to go to your PBM and say, I'm not sure why you included that drug on the formulary. I'm not sure why you excluded that. I want to know what the net costs of drugs are, factoring in the rebates and other monies you're paying me on a drug-by-drug basis. I need to know what the net costs are so I can compare them and figure out what I'm actually paying for. And so I can decide what to exclude and what to include. You also need the ability to customize your formulary, because if you discover that your PBM is including drugs you shouldn't be including, you want the ability to customize. You need the ability to customize prior authorization and step therapy programs. You need the ability to renegotiate your guarantees. You shouldn't have static guarantees for 3 years. You should be able to keep up with the marketplace if prices get better. You also need the ability to carve out a specialty drug. So if you're not getting a good guarantee, you should be able to go to another pharmacy and get a better one. You should not let your PBM have total exclusivity. You should require your PBM to disclose all pharmaceutical manufacturer contracts and all pharmacy contracts to you so your auditor can check them. And then finally, you should have the right to terminate whenever you want on 90 days' notice. You should not be locking yourself into 3-year contracts. If you don't need to exercise it, you won't. But if you do need to exercise it, you can. So you may look at me and say, those are pie in the sky. Nobody can get those. I'm telling you, you can get every one of those. We do for our clients. Our coalition has them. There are PBMs in the country that will give them to you and will also give you very good services. If you're sitting on a contract that doesn't have those, you should go out and get them. If you do, you will change the marketplace. Once you get those, you then have to exercise your rights. You have to get the net cost information. You have to customize your formulary. You have to renegotiate specialty drug prices if you can get better ones. You have to exercise carve-out rights. You have to monitor and respond to the marketplace changes if the FDA approves a new drug. If drugs lose patent protection, if drug prices change, you've got to respond to the marketplace. It's not static. Now, every one of you may be thinking, how the heck am I going to do that? I'm a little plan of 500 people. I'm a little plan of 5,000 people. How am I going to do that? If you're little, you need to hire somebody to help you do it. It doesn't cost that much. If you're bigger, if you're a group of 10,000 covered lives or 20,000 covered lives, you're going to spend about $50,000 to $100,000 doing that. If you block one high-cost drug, you'll save that amount of money, that annual salary for the whole year. One high-cost drug, if you're getting hundreds of high-cost drugs, you're going to end up way ahead. So an additional way to change the market, you have to require every consulting firm that you're using or that you're considering to use to sign a conflict of interest disclosure form. You should not be using consulting firms that are being paid to feed business to your PBM. It's an obvious conflict of interest. And in that conflict of interest disclosure form, you should say something very powerful. And the powerful thing should be, if we discover that you breached this by not disclosing what you actually are getting from the PBM, if we discover you falsified this, you're going to owe us money in the form of a liquidated damages penalty. Because if you just get them to execute a form and there's no penalty in it if it's not accurate, they can easily give you an inaccurate form. So put a damages penalty in it and make the damages penalty big. And then say to the consulting firm, sign it. Make our firm sign it and make every other consulting firm you talk to, that you're considering, that you're using, sign it. If the penalty says you're going to owe us $5 million, you'll see how many consulting firms won't sign that agreement. You'll be shocked. So if you do what I just described, here's how you'll change the market. If your plan demands and is only willing to execute a PBM contract that has reasonable terms in it, your plan is going to dramatically reduce your plan's costs, position your plan to control its costs, force PBMs to disclose what they're actually doing. That will force PBMs to act in your plans and your patients' interests. It will result in lower drug manufacturer prices. And also, it will get the consulting firms to act in your interests instead of the PBM's interests. So you will essentially change the marketplace. Long-term fixes. For real long-term fixes to occur, we need big players. And by big players, I mean very large state governments. For instance, Florida's big enough. They have the 5th largest Medicaid program in the country with $26 billion in annual costs. Or a large company like Amazon, Walmart, Kaiser, Anthem, or the federal government for Medicare or for the federal employee program. So what could a large player like that do? First, in terms of quality information, going back to the two things we're missing, quality and price. First thing, they've got to address the quality problem. How do they do that? They can easily create a web portal and put on that portal information about every single drug, like the information I just gave you about Abilify. Why isn't the federal government doing that? Amazon could do it, Walmart could do it, the federal government could do it, lots of players could do it. Florida State could do it. It doesn't cost that much, probably several $1 million. Create a web portal. Let us have some information about the quality of drugs. And then make all that information available to everybody. How about pricing? What could a large player do? This is really fun. Think about this. We need price competition. Think about this as a remedy. The large player needs to renounce secret deals, renounce rebates. No more of that. The large player, Walmart or Amazon or the federal government, needs to say, we're not doing that anymore. We're going to do it differently. We're going to create a bid day. One day in September, let's say September 1st at 9 a.m., all manufacturers tell us your net cost of your drug. You're not allowed to rebate it anymore. You're not allowed to give out coupons. You're not allowed to discount your drug secretly. We want to know your net cost of the drug. We're going to publish it. We're going to lock you into it for 6 months. We're going to publish it. We're going to publish it by therapeutic category. So everybody in this room who's taking an antidepressant can look up all antidepressants and figure out what the manufacturer is willing to offer the drug for. And see that some of them are at $4, some are at $5, some are at $8, some are at $30, some are at $400, and some are at thousands. Right? Every drug on the portal, locked in. And then 6 months later, give the manufacturers a chance to change their prices and publish those again. What will happen? The manufacturers that bid the high prices the first time around, they're going to lose market share, right? So with the second bid day, what are they going to do? They're going to look at the lowest cost prices, and a lot of them are going to underbid. What will the manufacturers who gave very low prices do on that second bid day? Well, they're going to scratch their heads and they're going to say, whoa, everybody knew what our low price was. We're going to have to bid lower. So what are you going to have created? What will Amazon or Walmart have created or Medicare create by doing a bid day like this? Price competition. Drug manufacturers will have to compete on price, right? It's a little more complex than that, depending upon which big players do it. You have to figure out how you work in the pharmacy costs. But the bottom line is, by getting that, you will actually have a market. You'll actually have quality information and price information. Doctors will prescribe more wisely. People will take drugs more wisely. Drug prices will decrease. Drugs with limited benefits or very high risks will have far less use. Manufacturers of such drugs will have to drastically reduce their prices. Manufacturers will have to stop spending so much money on wasteful drugs. Manufacturers will devote more of their resources to better drugs. We'll have a better marketplace. So I'm out of time. Time for questions.
So I'm not sure if this is this on? So come up to the mic if you have questions. Linda, real quick, are you going to be able to share this PowerPoint with our attendees?
Absolutely.
Okay, great. So we're going to be sending out attendee materials, and you'll get a copy of it. I saw a lot of folks scribbling notes and taking photos. And also on the great idea about the newsletter. We do newsletters and blogs, so those topics are all great. That's something that the coalition can do and can push out to our members. So Dan, you're up.
Hi, I'm Dan Ross with MedVision, and I've followed Linda a long time. One of the great things that I think she brings up is, just realizing that we need to read contracts and try and understand them. One thing I was wondering if you could comment on, Linda, is that there's a lot of rumors in the industry of fiduciary liability on the part of plan trustees, and the fact that they're held to the same standards as they would administer in a 401k. I was wondering if you're seeing any lawsuits or any talk about plan sponsors being held financially liable on behalf of by their plan sponsors or by their members?
So I'll start by saying I followed Dan Ross a long time. He's a terrific guy. If you don't know him, you should get to know him. He's a terrific guy. Fiduciary liability, the first lawsuit we started was about ERISA fiduciary liability. We were alleging that PBMs should be held accountable as fiduciaries under ERISA. I think they should be held accountable as fiduciaries. As a fiduciary, you have to act solely and exclusively in your plan's interests. The courts have not held them to be fiduciaries, unfortunately, but actual plan trustees are, in fact, fiduciaries. They are fiduciaries of their plan, so they do have to act solely and exclusively in their plan's interests. And if they know anything that is going wrong, they're obligated to try to fix it. So yes, you are a plan fiduciary, and yes, you should do everything you can to try to fix any problem that you know is wrong.
Linda, could you advance? Actually, you have a conclusion slide, and I know you didn't get to it. One of the things that Linda has in there is to join a coalition that has an airtight PBM contract in place. There's also the opportunity within our existing coalition if the employers are all moving in the same direction. So I don't know if you have any advice on next steps for us.
So I would urge everybody in the Florida Healthcare Coalition to do one or both of the following two things. They're in this slide. First, you should conduct a contract-focused RFP. Contract-focused. Pay attention to the contract in the RFP. Don't pay attention to a questionnaire. And put in place a better contract. Or join a coalition that already has an airtight PBM contract in place, but you gotta make sure it's a good contract. Most coalitions do not have good contracts in place. I know that because I've been hired to review them. So that's one approach. Another approach, or a complementary approach, is to work within the Florida Healthcare Coalition to try to move all of these agendas forward. So the Florida Healthcare Coalition could be disseminating information. It's already disseminating a lot. It could disseminate more. It could also arrange to put in place a better contract that you folks could take advantage of. You could do both of those. You could put a better contract in place for yourself, and you could also help the Florida Coalition do it for all members that don't have the resources to do it for themselves.
Linda, excellent presentation, and I strongly recommend everybody to get a copy of this presentation and use it as a roadmap, because you have put out some terrific questions and ideas that employers should think of. I'm speaking from my background as a CFO, as well as our association have run dozens of events on this topic, and my recommendation is you need to be tireless, you need to be relentless. Take these ideas and put them into motion. But from the CFO standpoint, Linda, I mean, we're equipped. We review dozens of contracts every year, and if you, in the audience, if you have not engaged your CFO, you can be a huge hero here. There's not only loopholes, there's plenty of savings that can be achieved. And I'm curious, Linda, when trying to approach that CFO to get him or her better engaged in this discussion or in this process, what suggestions do you have?
Well, generally, I would tell you that by putting in place a better contract, you're going to save about 10% of your drug spend. If you do nothing else, you don't change a single other thing, you just put in place a better contract that is free of loopholes. All the loopholes I described, your cost should go down about 10%. So multiply whatever you're spending right now. If you're a 1,000 life plan, you're probably spending more than $1 million. 1.2, 1.4, 1.8, depends upon what your combination of plan beneficiaries is. So a savings of 10%, that's not inconsequential. If you're a 5,000 life plan, you're probably spending $7 or $8 million. 10%, that's getting close to $1 million. If you then do things to impact the actual drug use, get rid of high-cost drugs, customize your formulary, put in better customized prior authorization programs, exclude drugs that you shouldn't be covering at all, like the ones that I listed, Vimovo and Duexis, and acne treatments that cost so much money. If you exclude them, you will start saving 20 to 30% of your costs. So if you know those numbers and you go to your CFO, I think that should help you move the dime, move off the dime.
Okay, we could do the 2 questions from Dawn and Lois, and then we'll gotta get back on track. Go ahead, Dawn.
All right, I will try to be brief. One thing that you didn't mention that I was curious about that is a contracting issue for PBMs is the site of distribution. There are a number, I do DGH Consulting, I'm Don Holcomb. I do a lot of work with physicians that are dispensing physicians. And what we're seeing is legislatively, on the pharmacy side, there's a lot of controls being put as to what PBMs can do regarding definition of pharmacy networks and limitations. But we haven't seen any discussion about how they're trying to also limit and control the dispensing physician, which can be one of the most cost-effective solutions, because eliminate other types of things, but in the physician world, they tend to bill only for what is actually used, whereas we're seeing hundreds of thousands of dollars being just shipped from PBMs or specialty pharmacies that they, like you, talk about the loopholes, and they have an incentive to just keep pumping the drug out. Employers are paying for it, the patient is receiving it, it can't be returned. So if you have an opportunity, I'd love to talk more about that piece of these contracts that we haven't addressed yet.
Okay, so very quickly, a very key component of saving money is making sure that the quantity of the drug that's dispensed and the site of dispensing is controlled. So if your PBM is dispensing 90-day fills of oncology products instead of 14-day fills, you are wasting a lot of money. And I guarantee you, your PBM may be doing that and probably is doing that. If they're dispensing 90-day fills of any specialty drug, even the maintenance ones, like the rheumatoid arthritis or multiple sclerosis specialty drugs, they're maintenance drugs that people get on and they stay on for quite a while. But very frequently, their bodies become intolerant to them at some point, or they discover they're not working at some point, and then they switch to another one. If your PBM is allowing your members, lots of them, to buy drugs that cost $5,000, Enbrel and Humira roughly are about $5,000 every 30 days, and they're dispensing them in 90-day fills, at some point, it's reasonably likely that a large part of that fill is going to get wasted. So even the maintenance drugs shouldn't be dispensed in 90-day fills. They should be dispensed at most in 30-day fills. And then, as you said, site of dispensing is very important. Most contracts are entirely silent about it. Most plans are entirely ignoring the issue. You shouldn't. It's costing you a lot of money. Contracts should not be silent on the issue. You should take control of this, and you should be looking at it. And again, if you're really small, you can't. You need to rely on an outside player. But if you're a reasonably decent size, I would say 5,000 covered lives or more, you can probably do some of this in-house, because you'll save enough money in the first couple of weeks to pay for an annual salary.
Good morning. I'm Lois Adams, and I have been a pharmacist for over 50 years and have been in this industry that long. You had a wonderful presentation, and I've been dealing with PBMs for a long time. We just passed a law in the state of Florida which makes PBMs have to register with the Department of Insurance. Now, how much that'll do, good. At least it makes them registered is the nose in the tent. But, I mean, and we needed to start somewhere. But unlike many other states, Florida does not do a really good job in regulating them. They have no regulation at all, so they can do whatever they want to. As far as some of these, I sat on the Medicaid DUR board. One of the biggest expenses that the state of Florida had was for Abilify. And Abilify was being given to patients who were 80 years old in nursing homes, and we were paying for it. This 90-day supply that you talked about, you were spot on. The 90-day supply, the last take-back day, and we have about 3 or 4 a year from the DEA, they collected over 447 tons of medicine that people didn't use. Now, when you have that kind of waste, and that's exactly what it is, you can just imagine what we're paying for. The other thing is people throw all that waste down the toilet, down the sink, and it gets into the water supply.
Fish.
Pardon?
Poor fish are taking Abilify every day.
That's right. And the thing about it is I testified before the Senate in the state of Florida, and I told Senator Negron, when your little boy starts talking like a little girl, you're going to understand what I'm talking about. The other thing is that these PBMs steer patients to their own pharmacies, like a Credo and some of those places. In fact, the people who are really taking care of the public and in the various communities can't even compete because they can't get into the network. Because if they find that you're even sending anything to anyone over 50 miles, then you get cut out of their network. These closed networks are a hassle. I mean, people take care of people. That's not the way healthcare should be practiced, and you have to talk to a conveyor belt. That's what I call conveyor belt pharmacy and whatever. But I loved your presentation, and I love your slides. Thank you.
All right, thanks, Linda.
Everything she said is true. Everything she said is true. The government needs to do this better, but my only footnote to that would be, if you sit around waiting for the government to do this better, you're making a big mistake. If you want to change the prescription coverage industry, don't wait for the government to do it. It's not going to happen that way. It's going to happen by the marketplace responding and demanding that they get quality information, efficacy, safety, side effect, and price information. Any other questions?
Thank you, Linda, very much.